Hello, welcome to my channel. So today we are going to go through the general embryology lesson 4. So specifically we'll go through fetal period and the prenatal diagnosis. So this is what we'll be going. So this is our objective. So the fetal period, we are going to go through the changes in the trophoblast, the placenta, the umbilical cord, the twinning. Then we are going to go through the birth defects and the prenatal diagnosis. Okay. Okay, but first things first. So in this chapter, due to the nature of the chapter, which is easy to understand and has no role in understanding the other chapters, most of other material in this chapter will not be discussed in our session, but they are still included at college or the university that you are at. The reason is that here we are mainly focusing on the subjects that link to each other and lose those that may be difficult to understand by reading the book alone. Then the only materials discussed in this section regarding this chapter are the ones we are discussed and usually only the outlines. Okay, usually only the outlines are the ones which have been discussed. Okay, so we're going to start with the changes in the trophoblasts. I'm sure this is one thing we have discussed, but this is more like a recap previously. And then we are going to get into details now into the fetal period, what happens exactly. Okay, so we are going to start with the changes in the trophoblasts. I'm sure in the previous lessons you understood that trophoblasts are going to differentiate into trophoblasts and gen. So those are some of the things we'll be repeating again. Okay, so cytotrophoblast cells from the ends of the stem villi invade the maternal spiral arteries and undergo an epithelial to endothelial transition. So they undergo an epithelial to endothelial transition to convert the small diameter high resistance arteries to large diameter low resistance vessels to increase the blood flow. Okay, so this is one of the trophoblastic invasions. Okay, but this is specifically the first trophoblastic invasion that tries to convert the blood vessels. But this is usually successful in two invasions. So where they undergo the transition from an epithelial to endothelial, then they will change the blood vessels from the small diameter high resistance arteries to large diameter low resistance vessels to increase blood flow. Okay, so initially the barrier between the maternal and the fetal period and the fetal blood is composed of 4 layers. You have the syncytium, cytotrophoblast, the mesoderm, we have the connective tissue, and we have the capillary endothelium. Then by the beginning of the 4th month, cytotrophoblast cells and some connective tissue begin to disappear, progressing from the smaller to larger villi, and thus the barrier is reduced to the syncytium and the capillary endothelium only. Okay, so that's what happens. So this is what we are talking about. The barrier is formed by the syncytium, cytotrophoblast, connective tissue, and the endothelium. Okay, then we are saying by the beginning of the 4th month, the cytotrophoblast and some connective tissue begin to disappear. So we move from A to B. So B, we have the barrier is formed by the syncytium and the endothelium. Okay, that's what we are talking about. Then let's talk about the chorion and the desodon. So with further development, the chorionic villi on the embryonic pore grow further, and this part of the chorion is called the chorion frondosum, while those on the embryonic pore degenerate, and this part is called the chorion larvae, and it is smooth. Okay, so that's what we are going to learn first. So we have the chorionic villi, on the embryonic pore where the embryo is. Okay, so further and this with further development, this part, the chorionic villi on the embryonic pore will be called the choriony frondosum. Okay, the choriony frondosum on the embryonic pore. Okay, while those ones on the embryonic pore degenerate, and this part is called the choriony larvae. So it's just where on the chorion larvae, we are saying the chorion larvae, it is smooth. So you have two parts. You have the chorion frondosum, which is on the embryonic pore, and we have the chorion larvae, which is here. Okay, so that's about the chorion. Okay, so let's talk about the deciduum. So the deciduum is the functional part of the uterine wall that's shed during parturition. Then over the chorion frondosum, so the deciduum that is found on the chorion frondosum here. The deciduum that is found on the chorion frondosum is called the deciduum basalis. Okay, while the chorion that is found over the chorion larvae, this chorion larvae is here, then the deciduum that is found on the chorion larvae is called the deciduum capsularis. Okay, then with further development, the capsularis, the capsularis is going to continue to stretch over, so meaning it's going to become this outer part. Okay, it continues to stretch over and degenerate. Thus, the chorion larvae comes into contact with the opposing uterine wall. So they're going to come in contact with this uterine wall. Then what is it going to become, or what is going to be called? So it will be called after it comes into contact with the opposing wall or the opposing uterine wall and degenerates and stretches. The deciduum capsularis will now be called the deciduum pariettalis after it comes in contact with the opposing uterine wall. Okay, that's what we are talking about. Then you have the amnion. Then the amnion also enlarges. Okay, the amnion also enlarges and fuses with the chorionic cavity. Fuses with the chorionic cavity. So this is the chorionic cavity which is here, and the amnion is going to continue to enlarge. This is what we are talking about. Okay, so they are going to enlarge and fuse together. So we have the fused deciduum pariettalis, the chorion larvae, and the amnion. So this is what we are talking about. So the amnion is going to continue to enlarge and will be fusing together with the chorionic cavity to form what? What is it going to form? So the amnion and the amniotic the amnion and the chorionic cavity are going to fuse together to form what we call the amniochorionic membrane, which ruptures during a labor. Okay, that's what we are talking about. Okay, so this is about chorion and the deciduum. Chorion and deciduum, this is what we are just talking about. Okay, so that's the chorion and the deciduum we were discussing. Remember, we said the amniochorionic membrane, one which is here, is one which is going to actually rupture during a labor. Okay, then let's talk about the fusion of the amniotic and the chorionic cavity. We said that the amniotic cavity enlarges further and fuses the chorionic cavity to form the amniochorionic membrane, which ruptures during labor. And we have established how the amniotic membrane actually even looks like. So this is also one of the important things that happens during labor, because this is one of the hallmarks that we use to determine how labor is going to progress. Okay, and this is indeed very important to understand in embryology, how the amniochorionic membrane is formed. Okay, then let's look at the placenta. So by the 4th month, the placenta has two components. You have the fetal component, which came from the chorion frondosum. Then you have the maternal component, which came from the de pseudobasalis. Then also it also has portions of the de pseudobasalis, which are called the de pseudoparietalis, we are going to penetrate down into the lacunae without reaching the chorion plate, and these divide the placenta into cotyledons. The lacuna actually will remain in contact. So what we're just talking about is that after the placenta is formed, it has two components of the fetal component and the maternal component. Okay. Then apart from that, on the if you remove the de pseudobasalis, okay, you remove the on the de pseudobasalis, if you remove the de pseudobasalis on the maternal component, you are going to have where the chorionic villi, or where we are the chorionic portions of the de pseudobasalis or the de pseudosepta penetrate into the lacunae without reaching the chorionic plate. So they make these things you are seeing, these demarcations. So one of these demarcations is what we call a cotyledon. So since there are many, that's why we say they are divided, they divide the placenta into cotyledons. That's what we are just talking about here. And this is also very important because we also use cotyledons in order to know if the placenta is intact. Okay, especially after labor, we need to understand if the placenta is intact. Okay. Then on the umbilical cord, you also need to understand that the umbilical cord has one vein and two arteries. You also need to understand the normal length. So in the comment box, just this is more like a work I'm giving you. Just comment the normal length of the placenta and the normal weight of the placenta. Okay. Normal length of the umbilical cord and the normal weight of the placenta at term. So two things: umbilical cord, the length, then the placenta, normal weight. Okay, what are the two things we would like you to mention in the comment section? So that's more like work. So you can just pause the video now and go and do the research and come and give me in the comment section. Then you continue with the rest of the tutorial. Okay, so that at least you'll be following. So what about placenta circulation? So we have high blood pressure in the endometrial arteries that pour into the lacunae or the intervillar spaces and bathes the villi. Then the negative pressure pushes the blood from the lacuna into the endometrial veins. Then of course, see, blood will now flow and will go to the fetus. Okay, so this is placenta circulation. Okay, so this is what we are just talking about. We have the maternal circulation, which is here, and we have the fetal circulation, which is here. So how do they communicate with each other? So they just blood comes from the high blood flow comes from the mother and goes into the lacunae. So these are the lacunae. Then you have the lacunae, and inside the lacunae are the intervenous spaces, and they're going to bathe the villi. Okay. Then we also have negative pressure. That's the one which is going to push blood from the lacunae into the endometrial veins. So that's how it's going to occur. So it's going to push blood into the endometrial vein. Then they're going to move into the fetal circulation. Okay, so this is the exchange through the placenta. Okay, and if I want to look more in details on the fetal circulation, yeah, there is a specific lecture in our anatomy and physiology series. So just check out the fetal circulation. Okay, so let's now look at the amnion and the umbilical cord. So the primitive umbilical ring is the oval ring that oval line of attachment over the amnion to the embryos in ectoderm. Then around the 5th week, it transmits. Then the connecting stalk, the yolk stalk, and the communication of extra and intraembryonic cavities. Then the yolk sac is still in the chorionic villi at this stage. When with further enlargement of the amnion, it causes it to surround all the structures together and give them an amniotic lining. Then the primitive umbilical cord and later completely obliterates the chorionic cavity. Then following the physiological herniation and the obliteration of the yolk sac and its vessels, the only contents of the umbilical cord are the umbilical vessels covered by Walton's jelly. Okay, so this is also one of the structures that are found on the umbilical cord, the Walton's jelly. Okay, so this is very good to understand. So the umbilical cord, remember in our preamble we mentioned that there's two arteries and one vein. Then on top of it has a shiny jelly, or it has a sheath, or there are a covering that covers the umbilical vessels, and that covering is called the Watton's jelly. Okay. Then let's also now change concept and look at twinning, but this is just more like an outline. So twins are either dizygotic. So dizygotic means they have come from two zygotes, and these ones are what we call fraternal twins. Or they are called monozygotic, which are of course are identical. Then dizygotic twins result from simultaneous ovulation of oocytes and their fertilization by two different spermatozoa, and they are non-similar in their features. So we have two egg cells that were ovulated on the day of ovulation simultaneously, one from the left on the right. Then of course they also were fertilized and by two different spermatozoa, and they even became implanted in the endometrium, and someone was told they're having twins. But the twins, since they are come from two oocytes and two different spermatozoons, these ones are known as dizygotic because we have two sets of zygotes. Okay, these are dizygotic. Okay, that's what we are talking about. So this is dizygotic twins. Okay, then dizygotic twins can either have a separate placenta and the chorion. Okay, then so this will be known as a dichorionic diamniotic. Okay, then others will have a fusion, or they have a fused placenta and a chorion. So this one will be a mono. This one will be dizygotic, but a monochorionic. Okay, since they have a fused placenta and the fused placenta, fusion of placenta and the chorion. Okay, so these are how we call them. So the dizygotic diamniotic, dizygotic monoamniotic. uh, Monoamniotic, and this is not monoamniotic, this is monochorionic. Monoamniotic, they would have been in the same amnion, but these ones are just having a fusion of the placenta and the chorion, so it's the monochorionic. Then this is the dichorionic. Okay, so these are some of the things you need to understand on the dizygotic twins. So what about the monozygotic twins, or the identical twins? Okay, so this was what we are talking about in the. We have already discussed this in the our preamble on dizygotic twins. Okay, we have already discussed this. So let's just move on to the mono. Okay, so the monozygotic twins results from the splitting of a single zygote at various stages, either the two-cell stage, the blastocyst stage, or the bilaminar germ disc stage. So this is where the stage, or this is one of the stages where the single zygote is going to split off and become two. So it's like the same cell has split off and has become now two cell there. Okay. So again, it's the same concept. We can have the two cells fuse together and they have one common placenta and a chorion. So that's one will be called the monozygote. monochorionic. Okay, so this will be a monozygotic monochorionic. Okay, then they can also have the common amniotic cord, the common amniotic cavity. So meaning they are together in the amniotic cavity. So this is one is known as a monoamniotic. So this one is a diamniotic, monoamniotic. Okay, hope you have gotten the concept. So this, in terms of zygosity, they are monozygotic. In terms of chorionicity, they are, these ones are mono, since they are one chorion. Then in terms of amniosity, they have two, so meaning this as diamniotic. But here they have the common amniotic cavity, so and the common placenta, so they have a monochorionic, monoamniotic. Okay, so these are the twins you are talking about, the monozygotic twins. So that's one thing you need. Okay. Then the monozygotic twins are resulting from the single zygote at various stages, such as the blastocyst stage, as we mentioned earlier. And also, we can have mixing of placenta vasculature, which can result into erythrocyte mosaicism. Okay, mosaicism. So we can have anastomosis of the placenta vessels and arteriovenous communication between the circulatory systems of the twins. And others, they even end up developing complications such as the twin-to-twin transfusion syndrome. So those ones, they all end up also again having the placenta vasculature that is compromised, meaning one will be the donor to the other, then the other one will be the recipient. So there are a lot of complications that can come about due to twinning. Okay. So this is what we have been talking about. But let's just look at the fifth. So in this lecture specifically, remember we said in our preamble that we'll be talking about the fetal period. But specifically, we are going to concentrate on the fifth through the 80th weeks of development. Okay. So during the fifth week of development, there is a very rapid development of the brain, and so growth of the head is considerable. Okay, and then by the end of the sixth week, the head grows even larger relative to the trunk, and the limbs grows the limbs show substantial development. Then, in addition, the neck and the trunk begins to straighten, and the heart is now four-chambered. Then by the seventh week, the various regions of the limbs become distinct and the beginnings of digits appear. Then at the start of the 80th week, the final week of the the final week of the embryonic period. Okay, so in our preamble we said the fetal period, but this is more over the embryonic period. Okay, so embryonic period at the final week of the embryonic period, which is the 80th week, the digits of the hands, so it's not fetal period. Fetal period is 9 weeks to termination of pregnancy, but this is the embryonic period, continuation of embryonic period from the 5th week to the 80th week. Okay, sorry about that. Okay, so at the start of the 80th week, the final week of the embryonic period, the digits of the hands are short and webbed. The tail is shorter but still visible. The eyes are open and the auricles of the ears are visible. Then by the end of the 80th week, all regions of the limbs are apparent and the digits are distinct and no longer webbed due to removal of the cells via apoptosis. Also, the eyelids come together and may fuse. Then the tail disappears and the external genitals begin to differentiate. Though the embryo at this stage will now be clearly as human characteristics. So, but we of course start going through this one by one. Okay. Then the fetal period. What about the fetal period? Remember in our preamble we said the fetal period is the 9th week to until termination of pregnancy, until delivery, until birth. So during the fetal period, from the 9th week until birth, tissues and organs that develop during the embryonic period, which of course we said the embryonic period was 5th week to 8th week. That's when we are talking about the development in the embryonic period. Okay, during the embryonic period, grow and differentiate. Then very few new structures appear during the fetal period, but the rate of body growth is remarkable, especially during the second half of intrauterine life. For example, during the last 2.5 months of the intrauterine life, half of the full term weight is added. Then at the beginning of the fetal period, the head is half the length of the body. Then by the end of the fetal period, the head size is only 1/4 of the length of the body. Then during the same period, the limbs also increase in size from the 1/80th to 1/2 the fetal length. Then the fetus is also less vulnerable to the damaging effects of the drugs, radiation, and microbes than it was as an embryo. Okay, so that's what you need to understand about the transition from the embryo period and embryonic period and fetal period. Okay, so this is a summary of changes during the embryonic and the fetal period. So in the embryonic period, which of course was 1 to 4 weeks, that was the first embryonic period, there was the primary germ layers and notochord development. Then also neurulation occurred, and there was the primary brain vessels, somites, and intra-embryonic coelms that developed. Then you have the blood vessel formations and blood forms in the yolk sac. The allantois and the chorion, the heart forms and begins to beat by the 4th week. Then you have the chorionic villi which develop and the placenta formation begins. Then you have the embryo folds, and you have the primitive guards, the pharyngeal arcs, and the limbs buds develop as well. Then the eyes and the ears begins to develop. The tail forms and the body system also begins to form. Okay, so this was 1 to 4 weeks. Then the 5 to 8th week we were just talking about previously, the later stages of the embryonic period, where the limbs that become distinct and digits appear, the heart becomes four-chambered, the eyes are far apart, and the eyelids are fused. Then the nose develops and is flat. The face is more human-like. Bone formation begins. Blood cells start to form in the liver. Then the external genitalia begin to differentiate. The tail disappears. Blunt blood vessels from the main internal organs also continue to develop. Okay, so these are the representative changes and the time frame. Okay, then the approximate size and weight, you have 0.6 centimeters, then here 3 centimeters, and here 1 gram. Okay, so these are also other changes that occur. These are other summary of changes that occur during the fetal development. Okay, so you have changes that occur in the 9 to 12 weeks, where the head constitutes about half the length of the fetal body, and the fetal length nearly doubles. Then the brain continues to enlarge. Then the face is broad, and with eyes fully developed, closed and wide separated. Then the nose develops a bridge. Then the external ears develop and are low set. Then the bone formation continues. Then the upper limbs almost reach final relative length, but lower limbs are not quite as well developed. The heart cannot be detected now at this period. Then the gender is distinguishable from external genitalia. The urine is secreted by the fetus and is added to the amniotic fluid. Then the red bone marrow, the thymus, and the spleen participate in blood cell formation. Then the fetus begins to move, but its movements cannot be felt yet by the mother. Then the body systems continue to develop. So the body starts to move by the fetal period 9 to 12 weeks, but the quickening or the movement of the fetus won't be necessarily be felt by the mother. Then the body systems will continue to develop. Then what about the 13 to 16th weeks? Okay, this is our approximate size and weight. Okay, so in this period, the head is relatively smaller than the rest of the body. The eyes move medially to their final positions, and the ears move to their final positions on the sides of the head. Remember, initially we said they were rotating. Okay, then the lower limbs lengthen, and the fetus appears even more human-like. Then you have rapid development of the body systems also, which occurs. Then let's go to 17 to 20. So the head is more proportionate to the rest of the body. The eyebrows and the head hair are visible. Growth slows, but lower limbs continues to lengthen. Then you have the venix caseosa, which is the fat secretions of oil glands and dead epithelial cells. And you have the lanugo, which is the delicate fetal hair, which covers the fetus. Then you have the brown fat forms, and it is the site of heat production. Then you have fetal movements, which are commonly felt by the mother, which is quickening. Now, the quickening will now begin at during this 17 to 20 weeks, but usually in the latter periods of the 17 to 20 weeks. Okay, then let's go to 21 to 25 weeks. Okay, so the head becomes even more proportionate to rest of the body. Then the weight gain is substantial, and the skin is pink and wrinkled. Okay, then let's go to 26 to 29. The head and the body are more proportionate, and the eyes are open. Then the toenails are visible. Then the body fat is 3.5% of the total body mass, and additional subcutaneous fat smooths out some wrinkles. Then the testes begin to descend down toward the scrotum at 28 to 38 weeks. The testis begins to descend down toward the scrotum at 28 to 32 weeks. So this is very important. Okay. Then you have the red bone marrow, which is the major site of the blood cell production. Then the many fetuses born premature during this period survive given intensive care because lungs can provide adequate. So that's what we also need to understand. So specifically, you also need to remember this point where we have said the testes are going to begin to descend toward the scrotum at 28 to 32 weeks, because again, if we are born prematurely, they will be born with an undescended testis or kleptocydism, and that's very important to understand. Okay, then let's also look at the 30 to 34 weeks. So the skin is pink and smooth. The fetus assumes upside down position. Then the body fat is 80% of the total body mass. Then the fetus says at the 3 weeks, and older usually survive if born prematurely. Then the estimated estimated weight is 2000 to 2300 grams. Okay, then let's go to the 35 to 38 weeks. So by 38 weeks, circumference of the fetal abdomen is greater than that of the head. Then the skin is usually bluish pink, and the growth slows as birth approaches. Then the body fat is 16% of the total body mass. Then the testes are usually in the scrotum in the full-term male infants. So even after birth, an infant is not completely developed. An additional year is required, especially for the complete development of the nervous system. Okay, then the estimated weight is 3,200 to 3,400 grams. Then the length will be, the fetus will be at 50 centimeters. Okay, so this is the summary of changes during the fetal period. So we talked about the early embryonic period from the 5th week to 8th week. Then we continued with the fetal period from the 9th week to the till term. Okay. So this is what we are from discussing, okay, up to 36 weeks. Then we're done with the fetal period. We are now going to talk about what we call teratogens. So a teratogen is an agent or influence that causes developmental defects in the embryo. So exposure of a developing embryo or fetus to certain environmental factors can damage the developing organism or even cause death. Okay, so what are some of the teratogens? We can have chemicals, we can have drugs, etc., etc. So, and of course, we're going to discuss those, etc., etc. Okay, so because the placenta is not an absolute barrier between the maternal and the fetal secretions, any drug or chemical that is dangerous to an infant should be considered potentially dangerous to the fetus when given to the mother. So alcohol is by far the number one fetal teratogen. Then intrauterine exposure to even a small amount of alcohol may result in fetal alcohol syndrome. Okay, one of the most common causes of mental retardation and the most common preventable cause of birth defects in the United States. Then the symptoms of FAS, we are talking about fetal alcohol syndrome, may include slow growth before and after birth, characteristic facial features we have short palpebral features, a thin upper lip, and a sunken nasal bridge. Then you can also have a defective heart and other organs. Then you can have a malformed limbs, genital abnormalities, and you have a central nervous system that is damaged. Okay. Then you can have behavioral problems such as hyperactivity. You can have extreme nervousness, reduced ability to concentrate, and an ability to appreciate cause and effect relationships are common. Inability to appreciate cause and effect relationships are common. Then we can also have other teratogens, which include certain viruses, so hepatitis B and C, and certain papillomaviruses that can cause sexually transmitted diseases. Also, pesticides are also common. Then you also can have defoliants, such as chemicals that can cause plants to shed their leaves prematurely. Then you can have industrial chemicals as well. Then also some hormones, antibiotics, oral anticoagulants and convulsants, anti-tumor agents, thyroid drugs, thalidomide, diethyl stilbestrol. Then you can also have numerous other prescription drugs. Okay, on LSD, cocaine, and even smoking. Then, of course, the risk of spontaneous abortion, premature birth, and stillbirth are also increased with fetal exposure to actually cocaine. So these are some of the teratogens that we have, and they are quite a number. That's why when you are the one who is giving medication to a pregnant woman, always look at the risks. Is it A, B, C, or D? Okay. Is this one indicated in pregnancy or not? Don't just give medications anyhow. Okay, so now we are going to do prenatal diagnosis tests. So there are several tests that are available to detect genetic disorders and assess uh, fetal well-being, namely, but specifically we are going to go through these three. We have the fetal ultrasonography or fetal ultrasound. Then we can have amniocentesis and chorionic villus sampling. So amniocentesis and chorionic villus sampling are invasive, while fetal ultrasound is non-invasive. So specifically, that's what we are going to talk about. So fetal ultrasonography. So if there is a question about the normal progress of a pregnancy, fetal ultrasonography may be performed. By far, the most common use of diagnostic ultrasound is to determine a more accurate fetal age when the date of conception is unclear. Also, it is also used to confirm pregnancy, evaluate fetal viability and growth, and determine fetal position, identify multiple pregnancies, identify fetal maternal abnormalities, and serve as an adjunct to special procedures such as amniocentesis. Then during fetal ultrasonography, a transducer which is an instrument that emits high frequency sound waves, is passed back and forth over the abdomen. Then the reflected sound waves from the developing fetus are picked up by the transducer and converted to an on-screen image called a sonogram. Then, because the urinary bladder serves as a landmark during the procedure, the patient needs to drink liquids before the procedure and not void urine to maintain a full bladder. Okay? Remember, the urinary bladder will serve as a landmark during the procedure. Okay, so this is prenatal diagnostic testing or prenatal diagnosis. So we are also done on the prenatal diagnosis. Then lastly, we are going to look at labor. So labor is the process by which the fetus is expelled from the uterus through the vagina and also referred to as giving birth in layman language. Then a synonym for labor is parturition. Parturition, okay, that's the synonym. Okay, so if you don't want to say labor, you can say parturition. Then true labor can be divided into 3 stages. So this is true labor, not false labor. We have the first stage, which is the stage of dilatation. This is the time from the onset of labor to the complete dilatation of the cervix. And this is the stage of dilatation. So this stage, which typically lasts 6 to 12 hours in Mount Para, features regular contractions of the uterus, usually a rupturing of the amniotic sac, and a complete dilatation of the cervix to 10 centimeters. Okay. Then if the amniotic sac does not rupture spontaneously, it is ruptured intentionally. Okay. Then that's the first stage. Then we have the second stage of labor, which is the stage of expulsion. And the time frame is 10 to 2 hours, and from complete cervical dilatation, and starts from complete cervical dilatation to delivery of the fetus. And this is what we refer to as the stage of expulsion, second stage of labor. Then the third stage of labor is the placental stage, and the time is 5 to 30 minutes or more. And then after delivery until the placenta or the after birth is expelled, the placenta will be expelled and its membrane by powerful uterine contractions. And this is what we refer to as the placental stage. Then other literatures, though it's not necessarily part of the true labor stages, it's more of after the true labor stages, there comes the fourth stage for recovery just. But of course, the true labor stages these are the 3 true labor stages. That one is just a stage of recovery, not a true labor stage. Okay, so they are the phases of labor, the stages of labor. Okay, then the first stage also has what we call phases. We have the latent phase and the active phase, and those are some of the things you need to understand about labor. But this, of course, is more like just a review on labor. And we are done. Any questions, you can check them out in the comment section. Feel free to ask the questions in the comment section. Okay, just ask anything you left behind, and any other questions you might have about concerning what we have also done so far from lesson 1 and 2 and 3. Okay, so we have come to the end of our tutorial. If you haven't subscribed, please subscribe and hit the bell notification, and see you on the next tutorial. Okay, so we are going to do our last tutorial on the birth defects. Remember, initially we are supposed to do birth defects, but we are going to do them in the next tutorial, just birth defects alone. Okay, and also we are going to go through some more stations on the birth defects as well.